So welcome to this fourth lecture on solving the toll of depression on populations. In this last lecture, I will try to give an overview of what I think should be done in research in the coming decade. And this is the fourth lecture of which I give for my retirement. And I give an overview of all the work that I've been doing in the past years. And I talked about prevention, about dissemination and simplifying treatments and digital interventions, and about how we can improve treatments and what do we know about treatments. And in this lecture, I will go through all the recommendations that I think are good to improve the field. And so I will still give an overview of what we're talking about. Why is population health, public health, important when we look at depression? Then I will summarize what should be done in terms of prevention, in terms of dissemination and simplification of treatments, how we can develop better treatments, and the next steps, how can we improve the impact of treatments. So first, the introduction. I've said it many times before, depression is a major public health problem. 80% of people suffering from it live in low and middle income countries and have very little access to treatments at all. It's a very costly intervention. It's also a disorder of the adult age, meaning that it's mostly production losses that we get from depression. Many people think it's treatments that makes it so expensive, but it's only a fraction of the actual costs. We looked at that in the Netherlands in these epidemiological studies, and we found that 80% of the costs of depression are production losses. People don't go to work, or when they go to work, they're less productive than when they would not have been depressed. So this is a study from Gavin Andrews in Australia, already quite old, but it's probably still true, probably worse than it's shown here. What they did is they estimated how much of the disease burden can be taken away by the treatments we have. And so they looked at years lived with disability. So that's a measure for quality of life. I won't go too much into it, but it indicates the disease burden. And they found that for any mood disorder, only 15% of the disease burden is currently taken away by the treatments in Australia at that time. But Australia is very similar to other high-income countries. So this is probably also true for Europe and probably also for parts of North America. You can see that the same is true for all other mental disorders. So it's not much of the disease burden that is actually taken away. But what they also said is, okay, but a lot of people who do get treatment, they don't get an evidence-based treatment. So suppose what happens if all these people who are in treatment would get an evidence-based treatment. And here you can see that for major depression, that would increase the disease burden that can be taken away by current treatments. And so that goes up from 16% to 23%, which is quite a rise. But we also know that a lot of people who are depressed or have another mental disorder don't seek treatment. So suppose that we were able to give everybody with a depression, regardless of if they seek treatment now. If we could give them all an evidence-based treatment, then still only 34% of the disease burden of depression can be taken away with the current treatment. So this is not good enough. We have to do better. And as I said previously, treatments are good, but if they're not used by other people, by people who use it, then the impact is pretty low. And that's the uptake is very low in high-income countries, but even more so in low and middle-income countries. And so if people go to treatment, it's, as I said in my previous lecture, 60% of people don't respond. So they don't get better. With a remission rate of 26%, the impact is still pretty low. So what is needed? We need basic research because we don't understand what depression is. We really don't know what it is. And we don't have a test or anything. We know that it exists because we see patients suffering, especially with the chronic and severe cases. But there is a large gray area. Are people depressed or not depressed? Do they suffer? Do they suffer enough to get treatment? And there is really no. We can better understand depression on a continuum than as a binary condition which you have or don't have. But we still don't know how to treat it or prevent it. So what we need is prevention. Can we prevent it? We should simplify treatments and implement them better. And we need better treatments, which do better than these 40%, 41% response rates. So first, can prevention help? I already told you in my first lecture that we have 3 types: universal, aimed at the whole population; selective prevention, aimed at high-risk groups; and indicated prevention, aimed at people with subthreshold depression, not meeting criteria for major depressive disorder. But they all don't have a diagnosis. If people have a diagnosis, we call it treatment or maintenance treatment. So where are we in this field? It's unclear if universal prevention works. Probably not, I would say. Probably it does not work. Maybe it does, but it's really unclear at the best at this moment. Selective intervention is promising. We found indications that it works, but probably most people who participate in selective interventions already have mental health problems. And that we can actually prevent the onset in those people, that's promising, but we're not certain how, with whom, and when. And that's also related to this low predictive strength of risk factors. We have lots of risk factors in mental health problems, but they all have limited predictive strengths, meaning that the majority of people in these risk groups do not develop a disorder within a year. Indicated prevention is a different story that works clearly, but the problem is that the uptake is too low to make an impact. So if we really want to make a difference, we have to focus on important determinants that have not yet been targeted and prevent large community efforts to prevent depression. Poor parenting, interparental conflict, family instability, children, maladaptive personality traits. And so if we really want to make a difference, prevention should start early in life, preferably even before children get born. Should be focused on children and parents, and it should be long-term and structural. So it's not only universal or only selective or only indicated. It should be all three, including treatment services across the lifespan. That's the only way to make a real difference. And I talked about more structural factors like inequality that are very much based within the political system, which have an enormous impact on mental health and the incidence of mental health problems. And if we really want to make a difference as a society, we should consider with all political measures that we take, whether they have an impact on mental health problems. That's the only way to really do something about mental health problems. And I know that a lot of politicians are now worried, especially after the corona situation, about mental health in youth. But at the same time, I don't see that they're willing to take the consequence of it, to invest more money, to really look at the structural consequences of policy measures like on inequality, on housing, etc., on mental health. What I do think is, when we go back to the more individual approach, I do think that indirect prevention and treatment is the way forward. We can make digital systems, but also including face-to-face and other interventions within settings as a university, that you talk with students. What's your most important problem? What are the things that keep you awake at night, so to say? And focus interventions on that, and then indirectly also focus on mental health. We can do that in universities, in high schools, in general medical health care, in the work setting. And I think that's the way forward. If we want to make a difference in terms of prevention and indirect treatment, these systems are the way forward. These are the most promising approach that I've seen over several decades. So simplifying treatments. As I said, traditional therapies, they're mostly for the rich and highly educated. And it's the overall, if you look at the total uptake, it's really very low. And the most important target groups, like I talked about prevention of depression, you should focus it on adolescents, because that's where the things happen. Preferably even earlier in life. But if you want to focus on when people get a depressive disorder, you should focus on adolescents. At the same time, we see that adolescents, like university students, are very much inclined not to seek help, because that's not what you do at that age. That's not what when you have a problem, you don't go to a professional. You talk with friends, maybe family, you try to solve things yourself, and your life is changing in all kinds of different ways. So the uptake in adolescence is really very low. Same is true in older adults or in ethnic minorities. And then we have talked about, low and middle income countries where the real problems are, because that's where 80% of all the people with a depression live currently. So I think what is important when we think about simplifying treatments is that any format is as good as the other one, as long as there is human support. And guided interventions are just as good as face-to-face interventions, but much better scalable. Unguided interventions, well, we now know that they're less effective than guided interventions, but maybe that's a matter of time. Maybe we can make these unguided interventions so good, for example with AI, that people don't notice the difference between guided and unguided. It could very well be possible that guided interventions are more effective because they have this personal contact with somebody, forcing you to do what you promised to do in the beginning. And if you don't do that, you know that after a week, this person will contact you and you will have to explain why you didn't do that. So this personal pressure could be the thing that makes a difference in terms of people sticking to the intervention. And so maybe if we do that in the right way, with artificial intelligence, people also have this same urge to continue with the intervention, even if they are inclined to stop with it. We don't know, but it could very well be that we can make unguided interventions just as good as other interventions. I talked about single session interventions, which are also a solution for groups who are not willing to seek help. We don't say, okay, you need a 16-week session, one session every week with therapists who will look through you, who will talk about your problems, your youth, how you are. No, we're going to give you one session. And we're going to talk about your problems, and we're going to explain how it works to do exposure, to do behavioral activation, to do cognitive restructuring. And maybe you can then go on yourself. But if you need more help, we're more than happy to give you another session. It's a completely different approach to what traditionally meant is with psychological treatment. And then we have the lay health counselors, going from where people, nurses in primary healthcare center or other people, lay people are trained to deliver psychological treatments. Yeah, and there are so many new developments. As I said, the interventions that are effective and that we've worked with in the past 20 years, they are traditional interventions. They sound very innovative and new and fancy because they're internet and digital interventions, but they're in fact very old-fashioned. And they don't make use of, for example, your smartphone, which you always have with you. There is a lot of research on ecological momentary assessment, ecological momentary interventions, where you look at real time what is going on with you, so that you answer a few questions every day a few times on how you feel, what you're doing, that kind of did you sleep well, how is your mood, how are you anxious, are you stressed? So then you get real-time measurements of what's going on. And we don't know what the impact will be. There is a lot of research. I haven't seen better outcomes than traditional treatments yet, but there's certainly this promise of improving the treatments and improving the possibilities to do something about mental health problems. Yeah, we see this increasing number of trials, but a lot of is still unknown. We need different designs. I said that already, that trials are also very old-fashioned, so to say. And with David Moore, we developed guidelines for how to adapt interventions during the trial, because that's what we need. When you examine digital interventions, you cannot just say, okay, this is the interventions, this is frozen, and we're going to examine that in the next 4 years. The world has changed 100% in 4 years' time in digital terms, so to say. But also artificial intelligence we don't know what the consequences will be, but it will have a major impact on this field. I expect that this will lead to a whole new series of possibilities to do something about mental health problems. But these have happened over time in the past decade several times. A lot of new promises that were gonna, change the field, better outcomes. But if you look at the effect sizes, they have been pretty stable over time. And so I'm not sure whether it's gonna happen. I hope so, but I'm not sure it will happen. So better treatments. We made this overview of all the effects of psychological treatments of depression, with all the effects for all the types of therapies, all the treatment formats, specific target groups, the relative effects, the secondary outcomes, comparisons with pharmacotherapy, the setting, primary care, secondary care. So anything you can imagine, what can be examined in meta-analysis is summarized in this paper. And I summarized it also in my previous lecture, but if you want to know the details, it's all in here. So I won't repeat that now anymore. So if you very briefly, all these therapies are effective, no significant difference. Treatment format doesn't matter as long as there's human support. Works in all kinds of target and age groups. Works on all kinds of secondary outcomes, not all, but most. It's comparable to drugs at the short term, more effective at the long term. Combined is the best. It also works in chronic and severe depression. And my recommendation would be not to give drugs without therapy. And that will be a tough one, but I think that's what many guidelines will say in the future. And I think that's a good thing. It's less effective in primary care, less effective in children and adolescents when people have comorbid substance use, and maybe less effective in chronic depression. Yeah, so why do we need better treatments? What you see here, and I talked about that more elaborately in my previous lecture, that's only 41% response and 25% remission. And this is what you see over time. And the effect sizes are, you see the regression line over time, it's completely flat. No improvement at all over time. And so we have been doing all these trials and we always find, okay, it works, it works, it works, it works. And over the years, we've seen that. That's why I'm a bit skeptical about innovations, better treatments. We don't see that in the numbers. And if you look, for example, at cancer rates or heart disease rates, you see that the disease burden really goes down over time. In most part because of prevention measures. People have stopped smoking. But it's still, even if you adjust for that, you see that the disease burden goes down over time for many other conditions. That's not true for depression. It's just one flat line. Treatments don't get better. We've looked, for example, also at the response and remission rates of care as usual across time. One flat line. You would expect that if treatments get better, that usual care would also get better over time. No, one flat line. So that's a very pessimistic outcome. So what should be done? Different focus of outcome research, reduce waste, a different innovation cycle, innovations in the process, stratification, sequential treatments, and focus on problems for which no good treatments are available. So, first of all, what we do in most research is that we focus on symptoms. So therapies are effective if the symptom level of depression goes down. That's how we define improvement. But that's a very limited way of looking at it. If you ask patients what is important for you when you go into treatment, what do you want to get out of treatment? They say that they want that their symptom symptoms are improved. Yes, of course, it's an important goal, but usually it's not the most important goal. People want to be a better partner. They want to be a better parent. They want to go back to work. They don't want these conflicts with their friends. That's what's important for patients. And so if we just focus on symptoms, that's a very limited way of looking at outcomes of therapies. And if you're interested in this, you should read this paper, which I wrote a couple of years ago in World Psychiatry. You can look at outcomes in all kinds of different ways. So not only from a patient perspective, but you can also look at from a therapy perspective. Because in CBT for depression, that's focused on symptom reduction. But if you look in psychodynamic therapy, depression is just that's a secondary thing. It's what matters is the interpersonal problems that people have relating to their childhood, how they were raised, how they were, what interactions they had with their parents, with their peers, the problems they had. And depression, that's just an outcome of these much more important problems. And if you change these problems, then depression will go away automatically. So depression is not relevant if you're a psychodynamic therapist. I don't agree with it, but you can look at outcomes of psychotherapies in completely different ways than we as researchers are inclined to do. And people working in practice, they do that every day, always, because they look at the patient and they talk about what is their problem, et cetera, et cetera. But I think in research we have done this too little. We should focus on the real problems that patients deal with in their real life. And we did that, for example, in the Lebanon trial by using the Cyclops, where you ask people to give the top 3 of their problems, just in their own words, very idiographic. And then afterwards you ask them, did that problem improve? And we found good effects on it. But it's a much more idiographic way of looking at outcomes. So we should focus on this is also important because we don't know what depression is. Sorry, I'm going too quickly again. Yeah, so that's also important because I said it several times. We don't know what depression is. And we can say, okay, depression is the symptomatology, but that's not how patients look at it. We, as a researcher, find it easy to say, okay, depression, that's something you measure in a questionnaire or in an interview. And then we show that our treatments reduce that symptomatology, but that's such a simplification of what patients experience. And who are we to decide that a mental disorder is only the symptomatology? Because we don't know what it is. So how can we say it's only the symptomatology? Okay. Yeah, so another thing is that I think we should reduce waste. And in our database, we see that about 80% of randomized trials have at least some risk of bias, publication bias. We have selective outcome reporting and spin. We see every time and time again that new treatments are not more effective. We see all these studies on all these specific subgroups, and when I read the abstract, I see, yeah, of course this works. Why would it not work? And so all these different formats work. And so we see this huge increase of randomized trials over time. It's getting worse every year, much more work for us because we have to extract the data for a data set. But it's also pretty useless Well, we do all these studies, while at the same time, the most fundamental clinical questions have not been answered. And then we do a study which is bad. We don't publish the results. We spin the results and do as if it's wonderful while it's not. So I think that's one of the major goals, to reduce waste in research. It's not only in our field, by the way. Ian Chalmers, who was key in the Cochrane collaboration. He wrote this paper, I think in 2009, saying that 85% of all biomedical research is wasted. And I think our field is not different. If we really want to make a difference, we should reduce that waste and use the resources for that research on the things from which patients can benefit. I think we need another innovation cycle. Because what happens is that clinicians are very eager to learn new methods, because they see that many patients don't improve. They see that treatments have limited effects. So there is a continuous need to find better treatments. And if you come with a new treatment which makes clinical sense, then it's a fashion in psychotherapy. It's a fashion in mental health care. Over time, there are all these new therapies which have come up, the third wave therapies, mindfulness, acceptance and commitment. Now it's schema therapy. And so all these new therapies come up with only limited evidence. So only limited, there are a few trials that are done, usually easy trials, in which this new therapy is compared with a control group, a wait list, or care as usual, and then you see that it's effective, and then the developers say, see, it's effective, it works, it should be implemented. And at the same time, it doesn't work better than the ones we already had. So this whole circus of innovation, all the energy, all the trials, or the training of the clinicians that they use it hasn't made one patient better. Maybe on the longer term, that will make a difference, because we don't know which treatment works for whom. So in the end, maybe there will be a subgroup of patients who benefit more from this treatment compared to that treatment. But when I would have to choose where would I put the money on, so that more people get better with the money we have, so to say, then this is not what I would put my money on. Because there are many other priorities where we can make people better with other approaches. I will come to that. Yeah, so I think there are all kinds of innovations in the process. Like what we found is that frequency matter. If you give sessions to people twice a week instead of once a week, the effect size goes up. Progress feedback. If you talk with people about how things go and they fill in questionnaires every couple of sessions, and the clinicians talk with the patients about how things go. Do you meet your goals? Are you still happy? Do you improve enough? That kind of thing. We see that also, there has been a meta-analysis from Kim de Jong in Leiden showing that works. And maybe there are other comparable process-related outcomes. Bruce Wampold says that a large part of the improvements is related to the quality of the therapist. That's a very complicated issue, I understand that, but if we could get better qualified therapists, maybe that also can improve. I don't know how, but that's really something that could patients could benefit from that. So, as I said, we have 900 randomized trials on psychotherapy for depression. Very few on chronic depression, very few on relapse prevention, very few on comorbid conditions like anxiety, personality, PTSD, substance use disorders. So, but that's the rule instead of the exception. Most people, especially in specialized mental health care, they have all kinds of comorbid conditions. So if you want to do a new trial, please focus on one of these and not on the interventions from which we know that it will work anyway. It will be good for you because you will have this positive paper about another intervention for a specific target group showing that it works. This is much more riskful, but it's for patients, it's much better. And then sequential treatments. So all therapies that have comparable effects, as we saw, but a lot of them don't respond, and certainly a lot of them don't remit. But we don't know what the sequence of therapies is. That's also related to another thing, stratification. We don't know who benefits from which treatment. So basically, you could give any treatment to any patient, and you can expect the same response and remission rate, regardless of the treatment. And we hardly know anything about the first, second, third. And I made this graph, which I hope is a bit clear. But this assumes that the next treatment is as effective as the first one. And you see the red line gives the response rate when people get treatment. And so the total response is on the vertical line, and the number of treatments is on the horizontal line. What you see is that so the first treatment 41%, and then the second treatment is 41% of the remaining 59%, and then you go on and on and on. And I wanted to show this first because I think this shows that treatment resistance is nonsense. Because treatment resistance is a new term which is used mostly in pharmacological research, saying that if people have not responded to two treatments, that they are treatment resistant. I would say that's the logical consequence of the limited effects of treatments. So this is just what you can expect. There's nothing strange with these people. It's just that they don't respond like you would expect. But it also shows that if you wanna treat 100% of these people, in some people you need 10 treatments. So and for remission, if you have done 10 treatments, there are still a lot of people who have not remitted. And these are probably optimistic lines. They're probably more flat, so to say, because when somebody doesn't respond to one treatment, the chance that that person will respond to the next treatment is smaller, while we assume here that it's the same. So this is something we just don't calculate in our thinking about treatments. We think a treatment works and it should work and that's it. But this is not a reality. We should think about what to do when a treatment does not work. So I think this is really a very important area for future research, what to do with sequential treatments. Then stratification, who benefits from what? It's pretty, I mean, if you look at patients, it's very obvious that there are some patients who benefit more from this drug than from that drug. The moment they start with that drug, they get better. The moment they start with this therapy from that therapist, they get better. But we cannot predict who that person is, who benefits from which treatment. Stratification, the question who benefits from what, that's really an important question. And I think, one of the promising areas is IPD meta-analysis. I showed this already a few times, especially IPD network meta-analysis, in which you look at different treatments and you can compare, you can see which characteristics of patients predict the outcome for this treatment compared to that treatment. That's an important area for the future. So, next steps. Yeah, so I think I gave a lot of ideas for the research agenda. The problem is that there is nobody taking care of it. And so if you're a clinical researcher, you have to compete with researchers in social psychology, in political science, in astronomy, in any kind of other branch of science. While we have a very clear public health goal, we want to reduce the disease burden of depression on a global level. And, but that's not how science works. That's not what the scientific community works. And I think that's a major problem. And that also means that we have all these researchers getting money to do research, which often doesn't contribute to the ultimate goal of what we should want, namely help all these people with depression across the globe and reduce the disease burden on a population level. And so I find it always very difficult to function in a scientific community while our societal goal is so clear and so focused, so to say. And I think that if I would be a funder, I would, and somebody somebody would want to do something in depression, I would always look at whether this research will contribute to a reduction of the disease burden. Maybe not now, but there should be some perspective in the future. And that's not always the case now. But as I said, I gave a lot of ideas, and I will retire now, but I will continue to contribute to this research agenda in the coming years. Thank you for your attention.